forward to the. Great. So let me go back. Okay. So this webinar is being recorded, and a link to the audio and video will be sent to all the people and all the members of the Maternal Health Supplies Caucus in a couple of days. The recording will be stored in our website, in the RHSC website forever. It will just stay in our library for the next 10 years, I suppose. You are most welcome to write your questions in the chat box. And without further ado, let me introduce our main speaker today, Dr. Jane Briggs. Jane Briggs is the Senior Principal Technical Advisor and MNCH Portfolio Lead at the USAID MTaPS project, and Jane works for Management Sciences for Health, as you know, a leader in pharmaceutical management. So without further ado, the microphone is yours, Jane.
Great, thank you very much, Milka. Hello to everybody. Good morning, good afternoon, good evening, depending on where you are. Thanks for that introduction, Milka, and for allowing this space to introduce you to our newly updated RMNCH forecasting supplement. If you could move to the next slide, please, Milka. I'm going to start off the presentation, and then I'll hand over to my colleague, Antualam Umar, who will then take us through an example of forecasting of a maternal health commodity. And then we'll be joined by some other colleagues from the Global Health Supply Chain Procurement Supply Management Project, from the forecasting and supply team, and from the country team in Pakistan, who have used this supplement in its earlier version. So just to go through the outline of today's presentation, it's a packed session, but each of the sections are fairly short. We will first go through the background, then we'll talk about the supplement itself and what the updates are that we have just applied, as well as the products that are included. We'll just go through the basics of quantification and forecasting, because not all of us are forecasting and quantification experts. And then I'll go through the contents of the supplement itself that we're introducing to you today. When I finish speaking, I'll put the link to the supplement in the chat, and that is available on these slides as well, which you'll get after the session. Then Antualam will go through a forecasting example for magnesium sulfate as an example of a maternal health commodity that is dealt with in the guide. And then our PSM colleagues will talk about some new tools that they've been developing and the experience in Pakistan. So I'm going to take myself off camera to preserve the bandwidth and move on to the next slide, please, Milka. Maybe just to go through a little bit of the background so that we understand why forecasting is important. If we increase the access to and the appropriate use of RMNCH medical products, we can save the lives of more than 6 million women and children per year. And a major component of access, as we all know, is availability. And one important way of ensuring availability is to make sure that we have accurate and timely estimates of what are the needs for supplies. And at the national level, results of these quantifications are essential for budgeting, resource allocation, and resource mobilization, as well as planning, procurement, and supply chain operations. So there's some pretty convincing reasons why we should be really interested in forecasting. And we hope that this updated forecasting supplement will assist technical experts and program managers when they're conducting quantification of needs for specific essential reproductive, maternal, newborn, and child health medical products. So on the next slide, just to highlight, people may be aware, if you could move to the next slide, please, Milka. People may be aware of the previous version of this supplement that was published back in 2016 under the UN Commission for Life-Saving Commodities. We have conducted an update. The updated version is in blue on the right. And this update is based on new recommendations from WHO. We included a new condition of management of severe hypertension in pregnancy, which was not included previously. As we all know, particularly in the field of maternal health, there have been some changes in the recommendations for management of postpartum hemorrhage, with some new medicines coming in for that. And for those interested in newborn health, there's been some slight changes to the management of PSBI. We've also included more updated data. We've changed the way the supplement is organized into organization by condition rather than it being by product, so that it's a more holistic approach for a condition. And we've included also an alternative approach for forecasting for magnesium sulfate and calcium glucate, which are often used in very small quantities. And Dwellin will go into that a little bit later. And at the end of the supplement, there is a really useful list of resources and tools that has also been updated. And in that, we have included the new quantification analytics tool that the PSM team will be speaking to a little bit later. So let me now look at the products that are included in the supplement. We initially focused in the earlier version on the 13 commodities of the UN Commission of Life-Saving Commodities, but we've expanded that in this version. And so for family planning, we include 3 products, just emergency contraceptive pills, female condoms, and contraceptive implants. The idea of this guide is that it is to include those products that are new, just being introduced, or underutilized. And so other family planning commodities are not included because there are other resources that deal with the quantification of those products. In maternal health, in addition to oxytocin, misoprostol, and magnesium sulfate that were included in the previous version, we have added heat-stable carbetocin, tranexamic acid, other antihypertensives, as well as calcium gluconate. And I think it's important for us to note with the addition of heat-stable carbetocin, as for all of the products, we talk specifically about what the indications are. And as we all know, being experts in maternal health at this stage, heat-stable carbetocin is only used for the prevention of postpartum hemorrhage and does not have all of the same indications as oxytocin does. Tranexamic acid is used, obviously, as we've been talking about in much detail in this group, is being used for the treatment of postpartum hemorrhage. And then for those that do crossover and work in newborn and child health as well, the newborn health commodities are shown on the next slide, please, Milka. We have added to the previous version, we have added amoxicillin and gentamicin in addition to the other injectable antibiotics for the management of possible serious bacterial infection for those cases where referral is not possible. And then child health, amoxicillin, ORS, and zinc. On the next slide, we really want to highlight the point that this resource is complementary to other quantification resources, which is why we're calling it a supplement. And so it complements other quantification resources, kind of like the Bible of quantification, excuse me, is the JSI guide from 2017, which is a quantification of health commodities. And I think also another important thing to note before we move on and look a little bit more at what quantification is, that this update has been very much a collaborative effort with a number of different partners, many on this call and others who have been involved in updating the guide and providing valuable inputs. And as well, we've had the chance to validate previous drafts of the version of this supplement in some of the countries with support from PSM project. So let's just make sure that we all understand the terms that we're using. This may be familiar with those of you that are involved in quantification on a regular basis and not so familiar for others. So just to make sure that we're all on the same page, quantification is the process of estimating the quantities and the costs of the products required and determining when those products should be delivered. And there are 2 components to quantification. One component is forecasting, which estimates how much is needed in a required period. And so it's a process of estimating future demand or estimated consumption. Supply planning takes into account the forecast quantity, what's already on hand and in stock, how much is coming, what needs to be held in country, to then orient procurement and shipment. The focus of today's session is on forecasting. All right, so let's move on to the next slide and show how those steps fit into the process. This is a nice diagram from the JSI resource I mentioned earlier. And here the highlight is that this supplement that we're talking about focuses on the RMNCH commodities we spoke of, and basically on those first few steps in the quantification process, the steps of preparation and forecasting, which are only a part of the quantification process. So now I want us to look a little bit at some of the data that is used for forecasting. And in this slide, we see that there are three types of data that can be used for forecasting. There is historical consumption data or logistic data, which typically comes from the Logistic Management Information System, which gives us the quantities of products dispensed or issued over a specific period of time. We also have service data, where we look at the number of services provided, number of visits where clients were treated or patients were treated, again, over a specific period of time. And that typically comes from our HMIS system. And then importantly for this discussion today, and the method that is used in the supplement is demographic and morbidity data. And here we're looking at the numbers of population targeted for specific services over a period of time. And it's based on data which is either prevalence or incidence of a disease or a condition in a specific population. And the ideal situation is that you have multiple types of data, which is reliable and timely. And based on that, you can conduct separate forecasts, which you can then validate or triangulate to come up with a final forecast. Now that's the ideal situation. And as many of you will know, if you've been involved in forecasting, there are often many challenges in that process. And here we are presenting some of those challenges that we have come across. And particularly for RMNCH medical products that we're talking about today that are underused or overlooked, that triangulation of different types of forecasts is not possible. Consumption data may not be available. Service data may not be available if they are new products or if they're at the beginning of being scaled up. And if there is data, it may not be adequate to be used. It may not be quality data. There's lack of indicative service data or logistic data as well. So the HMIS data is either poor quality or lacking. And so what we have really tried to do in this supplement is to focus on the forecasting using demographic and morbidity data, which is particularly useful when you have lacking data for these new products or underutilized products. For this particular methodology, if you don't have country-specific morbidity data or incidence data for all of the conditions, we sometimes need to use global estimates or refer to regional trends. And that's something that is presented in the supplement as well. We have this proxy data that can be used if country-specific data is missing. Scale up is sometimes a problem, particularly if we're talking about these new products that are being introduced. We can sometimes be a little bit ambitious, and it's good to be ambitious, but it can be challenging to stay realistic when you're incorporating those plans into the forecast. So I think it's important for us to remember that forecasting is not a one-off activity. The forecast should be reviewed at least every 6 months, because you'll probably have new information about the scale up, and adjustments that need to be made to the forecast and to the supply plan as well. So the forecast is not a one-off activity that you can say, okay, done and dusted, and move on and not look at it again for another 3 years. Another issue that we have found is problematic and is important as part of this forecasting exercise is to really encourage consultation between technical program and departments responsible for procurement. And so what we've seen to be useful in many countries is this multi-stakeholder quantification team, particularly for the forecasting step and the preparation, so that people who have knowledge of the program, the scale-up plans, commodity management practices can all come to consensus on the different assumptions that are needed in forecasting. And we're going to talk through some of those assumptions in a moment. So let me talk about what's in the supplement. The supplement consists of 9 different sections focusing on 9 RMNCH conditions. There's an introductory section first, which goes through some of the issues around quantification and forecasting. And then we dive into these 9 different conditions, which you can see on the screen. And then there's a glossary of terms. And as I said before, a very large section of tools and resources. The document is not intended to guide management of maternal health or child health or family planning programs, and it doesn't offer programmatic guidance, but it does provide information that is important for the assumptions and the hypotheses for forecasting, as well as sources of proxy data, as I mentioned before. In each of the chapters, for each of the conditions, we talk about the condition itself, we talk about product characteristics and other forecasting conditions, we talk about the data that's needed and where you can find that data, and then we show algorithms. For each of the conditions, there is a forecasting algorithm which shows the stepwise process of the forecast. And then we summarize the proxy data that's useful for that condition. And then we go into an example with like a case study that shows how forecasting can be conducted for that condition, the assumptions and the results given particular sets of data. And there's a huge section of references for each of these conditions. And what we have found in the use of this is really that it's a rich source of data and references for each of those conditions, which are useful for the forecast itself. Just to highlight that the supplement is only part of the package. The other parts of the package, in addition to the document, is a PowerPoint set of slides which highlight the forecasting algorithms, which we'll show you an example of in a moment. And there's also a set of Excel tools that can be used for forecasting. One of the tools for each of the conditions has dummy data in from the examples in the supplement, and the other one is a template that is empty with protected formulas to be used for a forecasting exercise. So I'm going to stop there and let my colleague Antoine take us through an example related to a maternal health commodity, which is the commodities of interest for this group. Thanks. Over to you, Antoine.
Okay, thank you, Jane. Hello, everybody. My name is Andualam Omar. I'm Senior Technical Advisor for MSH USAID MTaPS program. I'll be turning off my video to save my bandwidth and then continue with the discussion. And today I'm going to present to you an example. Can you go back, please? An example on the forecasting of magnesium sulfate needs for eclampsia. We'll also look at briefly on how to use the allocation method for both magnesium sulfate and calcium gluconate, which is the antidote for magnesium sulfate toxicity. Next, please.
Andualem, please, can you get closer to your microphone?
Okay, is it better now?
Much better, thank you.
All right, thank you, sorry. Okay, so magnesium sulfate is recommended by WHO, and it's according to WHO's 2011 guideline, which is still valid for prevention and treatment of eclampsia in preference to other anticonvulsants. And as you know, magnesium is an injectable anticonvulsant medicine. It's a life-saving drug and should be available in all healthcare facilities where pregnant ladies are taken care of. Health facilities using magnesium sulfate should have calcium gluconate, which is the antidote for magnesium sulfate toxicity in case of magnesium toxicity. Yeah. For settings where it's not possible to administer the full dosage of magnesium sulfate injections, it's recommended that even the lowest level health facilities refer these cases after providing the loading dose, so they can be better monitored and provided with full treatment at higher level. So this slide is to just describe to you the general steps taken when we quantify or forecast, in this case, the requirement, the forecast need of magnesium sulfate using the morbidity method. And the first step is to come up with the target population for prevention and treatment of eclampsia, because as we have said, magnesium sulfate is used in this case for the prevention of eclampsia in severe preeclamptic cases or the treatment of eclampsia when it happens. So we look at the total population, the proportion of population that's pregnant, and then the incidence of severe preeclampsia and eclampsia to calculate the number of cases then to be treated by magnesium sulfate. We also look at what is the proportion of number of cases that we can treat and prevent at the public health facility. All right. And once we have gotten the number of cases to be surveyed or treated, the other important aspect in the morbidity method is to get the quantity of each medicine, in this case, magnesium sulfate injection of the specific formulation to be used per one case, either for prevention or treatment. So basically the two important parameters in the morbidity method are number of cases by group, and then the quantity of each medicine for each group. And by multiplying the two, we can get the total quantity of the medicine that is required for the forecast period. In this case, magnesium sulfate. See, this is an algorithm that we have included in the guide, in the supplement, with regards to magnesium sulfate used for the prevention and treatment of eclampsia. As you can see, it starts from the total population, and then it goes to the calculation of the pregnant women in the country or in the region that we are considering, and then looks at the ANC attendance at the public health facilities to estimate the number of pregnancies that are served at the facility level, the public health facility level. And then we look at the incidence of preeclampsia to calculate the number of preeclampsia, and then we look at incidence of severe preeclampsia to determine the number of cases that will be provided magnesium sulfate for prevention of eclampsia. So that's one aspect of it. And then finally, we get to the number of the quantity of magnesium sulfate per prevention per one case to get to the total quantity of magnesium sulfate per one case for prevention. But there are also other actually three groups of cases that we need to look at. The other thing is there could be eclampsia case after provision of magnesium sulfate for prevention. So some portion of the cases, they could still, that is they could still develop eclampsia, and we need to treat that. The other scenario is those that have not been given magnesium sulfate for prophylaxis, even if they had severe preeclampsia, they would potentially develop at least some portion of them eclampsia, and that have to be treated. And the last group of patients or group of people to be provided magnesium sulfate will be those that get pregnant, but they don't go to the public health facilities, but eventually they might come to the public health facilities when they develop eclampsia, and they need to be treated. So all of these are considered in this algorithm, and finally we get to the total quantity of magnesium sulfate to be used for prevention and treatment of all these groups at the health facility. So this is one, it seems complicated, but it's pretty much simple, but we have already provided the algorithm with specific calculation steps and formula, which to make it very easy for people. And in addition to that, as Jen indicated, there are some tools, Excel tools that are used to help the countries to forecast the requirement using the algorithm, which follow the same steps and calculations. So saying that, but unfortunately sometimes, and given the fact that magnesium sulfate is supposed to be available in every health facility, especially if we consider health facilities, lower health facilities that only need to provide loading dose and refer, they might not need to have a lot of the commodity. So if we quantify for magnesium sulfate using the morbidity method, looking at only the number of cases estimated, it could be too low per health facility per year. So what we need to do is sometimes we need to consider an alternative method, which we call allocation method. And this allocation should be considered based on the pack size of the commodity that we are distributing, and also the ANC attendance. But it doesn't mean that we provide only the quantity that is used in a year, because the quantity that's used in a year may be like 2-3 ampoules or vials, if it's a low health facility, a low-level health facility, but it is required that we have at least a pack of that, because sometimes it's not also feasible to distribute small quantity, like 1 or 2 ampules if the pack size is of 5 or 10. So considering that, we need to determine the quantity per year per facility type, and then we multiply that by the total number of facilities in each group. In this case, we have as examples referral hospitals, regional hospitals, district hospitals, and health centers. We can also include other health facilities like health posts if they apply. And then we need to estimate the quantity per health facility per year, or you can do it per 6 months if you like. For each, we multiply the number of facilities by the quantity per facility per certain period, and we get to the total quantity of products needed to be distributed to each of these facilities per year. Or if you consider 6 months, it can be per 6 months. So that's another alternative approach for forecasting the need, but it can also include how much you need to distribute per year for these facilities. It goes just beyond forecasting. Next, please. So this is about calcium gluconate. As I have indicated, calcium gluconate is an antidote used against toxicity of magnesium sulfate. And there is generally less than 1.3% of chance of adverse drug reaction or toxicity due to magnesium sulfate. That means we might require only small amount of this product, but however, just like I explained in the case of magnesium sulfate, this is life-saving product and it has to be available wherever we are using magnesium sulfate. So we cannot use the morbidity method by looking at the number of cases expected per year to calculate this. So we have to resort to the allocation method in this case too, using the same kind of approach as I have explained for the allocation method of magnesium sulfate. But in general, one thing that we need to consider, or few things that we need to consider when we consider allocation method include to look at the fact that there could be high end forecast when you use that. That means it tends to overestimate the need per year, obviously. But we are risking, that means you are risking wastage. We are risking over storage of these commodities at each facility. So in order to minimize wastage, it's important to implement a number of approaches, including, for example, when we procure, we should not procure maybe for only 1 year. Maybe whatever we distribute per year even could be enough for more than a year or 2. So that's important. And something to go along with that is to look at the shelf life of the products. When we quantify, we need to be sure that what we get, can you go back please to the, we need to make sure that the shelf life of our products is long in general, otherwise it might expire before they can be used. We also need to do an assessment of the stock at each level constantly as much as possible, at least every quarter or every 6 months, to make sure that we do rotation of stocks from where they are not being used to where they are used at a higher rate. So if we do all this, maybe using the allocation method along with these approaches can minimize the wastage since it overestimates in general. Next, please. These are a list of data requirements, which we have already looked at when we went through the algorithms. But this is just to show that there could be multiple sources of data that we need to consider. And it is important to counter-check data from multiple sources and verify and rectify and use the best data source as much as possible. Next, please. Yeah. Next. Okay. So in the guide for each case that we have included examples or case studies with some background information provided, and then some data and assumptions for the forecast, including population growth rates, in this case, percentage of women that are pregnant out of the total population, incidence of preeclampsia, severe preeclampsia, and ANC attendance, the dosage, and so on. So this provides some kind of example for the users or the readers of the guide to exercise on how to use the algorithm and the tool. So this is just the information provided, including data and assumptions. Next, please. Then as part of the package, we have two sets of Excel tools. One is the template where you see blank cells for the users to input assumptions and data. And the gray cells are the ones that you see calculated once you input the data. But also we have each parameter on the left, as you can see, from A onwards. And then we have the input column where we have the calculations and the formula included, including with some assumptions, for example, in terms of percentage increase per year. And then the next two columns have are places where we either enter the data and or calculate. And then the tool generally forecast for the next 2 years, including the current year that you are in, for which you have data. So if you have data for example, 2021, and you are forecasting for the years 2022 and 23, so you can use the 2021 data as current year data, and then the tool calculates for 2022 and 2023. All right, next, please. So yeah, so ultimately the last thing is the last row shows you where you aggregate the requirement for treatment and prevention together to calculate the total quantity of magnesium sulfate required. So the first slide is on the prevention, the second is on the treatment. This is the tool with the input data. Okay, next, please. This is a tool with the input data for the prevention of eclampsia. No, can you go back, please? So as you can see, the white, go back, please, sorry. Yeah, as you can see, you have the white cells filled with assumptions and data. Go back, please, sorry. Next, yes, okay, stay here, please. No, no, next, hello? Next, yes, stay here, please. Okay, oh.
Where do you want me?
Yeah, yeah. Number four.
You were talking about prevention. Here in prevention?
This is treatment, yeah. Okay, here, okay.
Here, okay.
Yes, please, yes. So this is for prevention, and as you can see, you have the assumptions entered into the white cells, and the last row, you can see that this is the total requirement. The last row is the total requirement for the prevention. Row, the last row. Okay, yes, that is the total requirement for prevention. Next, please. Yes, so this is for treatment mainly, but you see at the bottom, you see two rows where you have first the total requirement for treatment, and then the red highlighted one is the total requirement. That is the sum of the requirement for prevention and treatment. Next, please. Yeah, and that's it from me. Thank you. And if you have any questions or comments, please put them into the chat box, and we will respond accordingly. Over. Lilian, to you.
Thank you, Andualem. Thank you.
Okay. Thank you.
Okay.
So our next presenter is Lilian Gu. Go ahead.
Okay. Thanks, Melka. Hi, everyone. I'm Lilian Gu from the GHSC PSM project, Global Health Supply Chain and Procurement and Supply Management. And I'm on the forecasting and supply planning team. And I'm happy to be here to talk to you about the quantification analytics tool, or the CAT, and its intersection with the supplement. So you can go to the next slide. First, a little background on the quantification analytics tool, which we call CAT.
Historically, there have been many tools for the two parts of quantification that Jane explained, forecasting and supply planning, including Quantimed, Pipeline, Excel, and other commodity-specific tools. Many of these tools are desktop-based, which means only one person can work on it or see it at one time. They have limited visuals and have not been updated for many years. Of course, the Excel tools generally are updated more frequently, but then they have the risk of people breaking the Excels. So CAT was designed to build upon all of this great work on these previous tools, but also be cloud-based with offline capabilities, have enhanced visuals, have built-in data quality checks, and be built in a way that's commodity agnostic, so it can be used for all health areas. So we have these two modules, the supply planning module and the forecasting module. We started with the supply planning module, and it was launched in December 2020. You can see in the map all the countries shaded in green. We have trained, and actually, since this map is from April, we have since trained South Sudan and Tanzania as well. And the forecasting module we just launched this month. We just had our first pilot training, and we're really excited about it because of the tool is really complete with the two halves together, and the data can flow between the two parts. And the forecasting module is really where we have the intersection with the RMNCH supplement. And these two graphs on the bottom are just to show you an example of the kind of visuals that we have put in CAT to make it to help users make better decisions and understand their data even better. So you can go to the next slide. So for the forecast module, we have two types of forecasting. Jane kind of explained the different methods of forecasting, but we basically have split it into two. One is consumption and one is tree. So consumption, you would do the extrapolation, but in CAT, the tree forecast, which basically is a very flexible method for users to draw their own tree, allows users to do demographic, morbidity, services forecast tailored to your own country needs. You can do the allocation method we just saw, and you basically are drawing these branches and boxes, adding them where they need. And for the tree forecast, we can basically add in any of these algorithms that we have seen in the supplement. And so that is our goal, is to add these 9 algorithms, or maybe more, because some of them maybe have simple versions, and then add them as templates to CAT so that users can access them. And in each of these algorithms, we would have start off with 0, and then the users can go in and fill each box. So maybe a little small on the screen, but you can see at the top, maybe it's country population. This example is for treatment of diarrhea, but it could be for any demographic method where you start from the country population and down to the children under 5, down to diarrhea cases, down to different sectors, down to different levels of care, and then finally to the products. And so there's a notes field for each of these boxes, and we can add in specific guidance so that we can link to WHO guidance or back to the supplement if there's additional guidance. So this is just a nice complement to the forecasting supplement we've seen. So we're excited to be able to add these templates for everyone. So that's all I wanted to share today, and happy to answer any questions in the chat.
Thanks, Lillian. That was a really useful overview of the complementarity between the new tool that you guys have developed, and that was very interesting. Just to finish off before we open up for questions, we wanted to allow the team in Pakistan who have used this supplement in an earlier draft to provide their perspectives of using it and how they felt, whether it was useful and so on. So we're a little bit short on time, but if the Pakistan team, I'm not sure, Dr. Tariq, whether it's you or Masood who'll be talking to this, but if you could do that in just a few minutes, that would be great. Thank you.
Well, thank you so much, Jane. I think it's a pleasure to be here, and I thank, Milka, and all of you, for providing this opportunity. Very briefly, I think Pakistan is one country where USAID has been investing in supply chains, and we have, sufficient data gains in terms of visibility for different supply chains, and family planning is one of them, where we have not only created appetite for, forecasting, quantification, and, leading it towards, domestic financing in the tune of $140 million. But I think it is creating much more appetite in terms of applying the same knowledge and skills and practice to the remaining supply chains in the country, actually. So this tool was actually applied, under task order 4 USAID work plans for Chemonics and PSM. We were looking at, how our multi-modeling can be applied in a situation for MNCH. And then I think we greatly benefited from this RMNCH forecasting supplement tool when we were trying to do forecasting for essential medicines for the provinces of Balochistan and KP. And we specifically applied this for the Balochistan, which is about, from a demographic perspective, is about, 8 to 10% of Pakistan, but the largest, province in terms of the distances and, geography, but people are less as compared to the larger. We were very tuned to using modeling and predictive, sciences while using procurement data, logistics data, market data, and DHI service data in terms of demographics to apply it for the gains of forecasting and quantification and supply planning. But this was something very different for us, where we found the tool actually helped us, from very, I think, mathematical algorithms. I congratulate, Jane and her team, Lillian and, other colleagues who have developed it. This is, we have found it one of the best tools where the comprehensiveness of the tool was very obvious when we tried to use it. But, for the limitations of data, which I think Jane alluded to earlier, that, there are limitations where we work in different countries and we don't have sufficiency in terms of data access or production of data and capturing of data itself. So we were able to only use it for the incidence actually data, that is 77.7% in Pakistan, and we applied it, in our settings actually. So what I see, I think we had, a couple of discussions internally, and my team, Masood and other, actually contributed in terms of technical knowledge gaining, in terms of how we can actually create an appetite and realization that MNCH forecasting quantification is directly and a direct determinant of maternal health in Pakistan, and many other countries. So I think what we are looking at this point in time is, Jane alluded to, how we can actually triangulate data between services, logistics, and, market data, and, supplies data and procurement and, number of things. But I think there are two kinds of appetite that we need to generate as public health practitioners at the global level. One, Pakistan has been very lucky in terms of USAID investing for almost 11 years to create, almost 85% of total, visibility on consumption data, procurement data, and pipeline data for family planning industry. But I think what we want to see is donors investing more in terms of creating this opportunity of using services data, and logistics data, and, I think commodity support in terms of creating this data, in different settings. Because I see one model that has worked very well under USAID investment is that when a country is supported by a total commodity with a condition that, your support will be weaning off in 4 or 5 years, the country gets onto its own feet and starts, domestic financing. I know Milka and all of us have been discussing it, in the last, meeting that we had in Nepal, where supply chain and, this data can be actually creating more appetite. That is one thing. The other investment required is the digital sciences. I know, multilaterals, bilaterals are working in Pakistan and many other countries. I think we need to create an appetite where we need to work on a real-time information system. The HIS is definitely very important in terms of creating trends, but it doesn't give enough information in terms of how we would like to see, reproductive health supplies, consumption data for maternal health, to create that appetite of, forecasting and quantification. So I'm very thankful to, our global colleagues who have created this, tool. It is one of the best, tools that we have found. It should be applied in both public and private sector settings. And I think most above all, what we found from our perspective was, that, a wastage factor also needs to be integrated into this tool already comprehensive enough. Although it is more required from a supply planning and quantification and pipeline monitoring perspective from a demand and, supply planning. But I think we still feel that, without, wasting factor, your quantification and forecasting exercises is not as much robust as it should be. I would like to invite my colleague, Masood. I know that, Jane said it's very little time, but if there's anything that you would like to add in just a minute, that would be great for the forum to hear, and then we'll have question and answer. Go ahead, Masood.
Thank you, Dr. Tariq. You have covered all the things. I just want to add that this is an excellent tool and we have utilized it for all the products. And we have also cross-verified the figures with the one forecast that we have done with the consumption. And we found this tool quite useful, and algorithms present in these tools are, you can say, the data provided here can be utilized for any kind of settings. And ultimately, all this and what the algorithms and formulas are providing and data sets provided in these tools, they provide us a strong basis to conduct any kind of forecasting. And I would highly recommend utilize this tool for any kind of forecast related to RMNCH commodities. Thank you from my side. Thank you, Jane. Over.
Great. Thank you very much. Just to end, this is how you can access the resources that we've talked about today, the supplement, the algorithms as a presentation, and the Excel tools. I also copied the link into the chat earlier on. We are translating it into French. That is almost ready. It's just being finally formatted and edited, and that will be out in the coming weeks. I know there has been interest in it in Spanish. At this time, we do not have financing for the translation of that, but if there are any interested parties that would like to go ahead and get that translated, we can certainly support the process. Milka, over to you to moderate any questions that may have come up.
Okay, thank you so much. This has been an excellent presentation, extremely useful. And I wanted to go back to the first slide. Yeah, here. Okay, so you have been responding to some of the questions, Jane, but I'm scrolling down the chat. So there's a comment from John Durgovich. The past is not always predictive of the future. Dispensing and logistics data and patient visit data may also not fully represent demand, even when relatively complete, timely, and accurate. There may be access issues, for example, or service expansion, promotion, interventions. Yeah, of course. And no, unforeseen events happen. No, nobody thought that we would get a pandemic in March 2020. So yeah, a lot of unknowns always. Any comments about that, Jane, or the team?
Hello. Okay. Can I come in?
Sure,
Yeah, go
sure.
ahead.
Yes. So I agree with John. That's correct, 100%. And that's why we have also have this tool that allows for countries to accommodate any expected changes based on some evidence, strategic plans to either increase service, or it could be about reducing because the number of cases will be expected to reduce, for example, if it is in terms of prevention of some bacterial infections, because we have also infections included in the guide. So generally, it's correct, and that's why we have this flexibility in the tools and the assumptions to accommodate for any future expected changes. But again, we encourage countries to start with the past data, because we also say that the past data is the best predictor of the future. Otherwise, people just tend to come up with some targets without looking at the trend and the real capacity in terms of absorbing number of patients and so on. So while I'm agreeing with that and the tool accommodates, please don't stop using the past data and learn from it before you go to the future. Thinking
Then
about
we
the
have,
future. Over.
Thank you, Andolim. We have also a comment from Chauvin Vega saying that the Global Health Supply Chain PSM project has found the section on each health condition really useful. Lots of great references as well. So make sure you look at those references. Jane has provided the link to the resources in the chat box. Kusum Tapa is asking, how do you calculate for calcium gluconate, as this is an antidote and only some cases would need it?
Yeah, I think that has been addressed through the presentation when I presented on the algorithms, especially on the allocation method. So by now, I think you are fine. Huh? This answer has been answered already, because that's we use the allocation.
Yeah, Jane is answered. Wonderful method. James
One of the points that has come up in the chat on that, I don't remember who raised that, but I think we talked about allocation of magnesium sulfate and calcium gluconate primarily because of the low volumes that are required for few cases that need them. I think one point that was stressed is that you actually need to make sure that you have calcium gluconate where magnesium sulfate is available. So as you do your allocation, you only take into account the facilities where magnesium sulfate would be required to be available, rather than all facilities in the country, for example, because the two are obviously linked together. That's the only thing I would add on that. I see there's some more. I think most of the questions prior to the end of the presentation have been addressed.
Yeah.
But I think there's a couple of ones that have just come in now. I haven't seen those.
There's one from Fantaye Dinkache. Can we insert another column to add forecast year 3? The case of Ethiopia, 3 years forecasting and 1 year supply planning is the practice. Can you modify the Excels to add another column?
Yes, Fantaye, and that's possible. We can either do it, or any user can include, because the formulas are clearly stated there. It's a matter of dragging, and you can do that by yourselves, and countries have done that already, but we can also consider including more than 2 years. Over.
Maybe just to add on that as well, the Excel sheets, both the example and the templates have been protected, just so that you don't accidentally mess up the formula with a slip of the cursor. But those protections are not password protected, and so you can unprotect it and make changes as needed, or hide the rows and so on. You can make any changes to that, but obviously it's at your risk, because you have to calculate for adding the extra column. You would have to transfer those formulas across. But yes, it's a resource that's available for you to make adjustments to as needed.
Yeah, and just to add on that, Jane, you can download these tools, and if you if you happen to spoil them in any way, you can still download another version and try, experimenting on it. Okay, sorry.
Good point.
Okay, there's a comment from Oleg Surov from Ferring Pharmaceuticals. Some countries were taking into account the oxytocin degradation and forecasting 1.4 multiplied by 1.4 doses. Can you comment on that?
I'll start off, and maybe Andrew Allen will have something to add. I think oxytocin degradation is primarily due to not keeping oxytocin in the cold chain. And so I think rather than forecasting for that, the solution is to ensure that the cold chain is sufficient so that oxytocin does not lose effectiveness. And obviously to look at other options if the cold chain is not reliable, to look at other options for the indications that you can use alternatives for. So I don't think that we should be including that as a forecasting sort of formula, but really focus on making sure that oxytocin is stored under the correct conditions, or looking at alternatives where that is appropriate. Andrew Allen, did you want to add to that?
There were also several questions on wastage. So I'm going to read Jane's response. The issue of wastage was not included in the supplement, as it is seen as more of an inventory management issue rather than a forecasting issue. All right.
Yeah.
Can I you
add?
wanted
Okay,
to
yes.
add something? Yes.
Yes. So I follow what Jen said, just to reiterate that this kind of calculation of including the wastage, that is wastage to my understanding, into the forecast would I think cover, or it might not make it evident how much wastage we are considering. So, and it's also not part of the forecast. By definition, the forecast is estimation of future consumption. Then the wastage is something that we consider in the supply planning part of the quantification rather than the forecast. But saying that, if you are applying 1.4 dose instead of 1, that means you are saying there is a wastage of about 40% of this medicine. And that's huge wastage. So just like Jen is saying, we need to understand why this is happening. Maybe it's about the cold chain, and it's making sure that this wastage does not happen and reduce. But maybe we can apply 5 or 10% wastage. That is what we see from countries to countries. And we can include that in the supply planning part of the quantification. Over.
Okay, we are at the top of the hour. So Jane wrote a last message there. We would love to hear any feedback from countries that are using this guide, and please do contact us if you need any more information. We're always at your service in English, French, and Spanish. So please do come to us if there's any need to know more about this forecasting guide. Thank you very much to the MTaPS and the PSM teams. You've done great work. And thank you all for coming to this webinar. We had a lot of participants, and we'll see you soon in our next webinar. Thank you again, Jane and team, and hope to see you soon. Bye-bye. Take care.
Thanks, Milka. Bye-bye.
Thank you, Milka. Good night. Thank you, everyone.
Thank you.
Bye.
Thank you. Bye-bye.
Jane, thank you.
Bye. Thank
Lillian,
you.
everybody. Good night. Good night. Bye. Bye.
We'll share the recording. Don't worry.